and welcome to the Davies Use Case webinar being presented by Nebraska Medicine on reducing catheter-associated urinary tract infections. This winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety. It's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health IT to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. This is outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and value. The have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT-enabled care delivery. It's my pleasure to welcome our speakers here today, and I will turn the presentation over to them, introduce themselves.
Good morning, this is Julie Feddersen. I am an academic hospitalist from Nebraska Medicine, and I am also our Chief Patient Safety and Compliance Officer.
I am the Director of Quality and Patient Safety.
Are you ready?
Okay. Yeah.
Good morning. We are from Nebraska Medicine, and we are here to present our Nicholas E. Davies Award of Excellence case study. A little bit about our health system. Nebraska Medicine employs more than 8,000 people in the Omaha, Nebraska area. We are associated with over 1,000 affiliated physicians, and our primary clinical partner is the University of Nebraska Medical Center. We consist of two main hospitals, which include our tertiary quaternary academic medical center, the Nebraska Medical Center, as well as a community-based hospital in Bellevue Medical Center. We have over 39 specialty and primary care clinics. We're offering over 50 specialties and subspecialties. We are a level 1 trauma center. We have about 809 licensed beds between the two hospitals in Omaha and Bellevue. And yearly, we account for over 31,000 discharges and almost 500,000 outpatient visits, as well as close to 100,000 ER visits. I wanted to talk a little bit about our mission, since that is what sort of guides us through our selection around quality and patient safety efforts. But that mission is to lead the world in transforming lives to create a healthy future for all individuals and communities through premier educational programs, innovative research, and extraordinary patient care. Supporting that mission really is a series of values that our organization has used to really reflect who we are. Those are formulated into a framework called I Teach and includes things like innovation, teamwork, excellence, accountability, courage, and healing. Many times you will hear our values referenced to as we select projects, as we talk about how we try to improve processes throughout our organization. Earlier in 2016, we started to do some more in-depth strategic planning about our organization and how we wanted to prioritize and what we were focused on as an institution. Out of that was created a model, a sort of a strategic map around domains where our patient safety and particularly the patient themselves are at the center of those domains. Our brand promise, what we've been known for years in the Omaha and Nebraska, Iowa region, is that promise of serious medicine and extraordinary care. And these domains reflect that prioritization and focus on making patient safety foremost in everything that we do. So our case study today takes into account some of that domain around patient safety and our effort to achieve zero harm. So this is a case study around catheter-associated urinary tract infections, sort of our call to arms around this problem and what we used and how we used health IT to really pave the way. So a bit of background, CAUTI is a very common, or catheter-associated urinary tract infection is a very common sort of metric that organizations follow, obviously, because of its implications on annual goals for infection prevention, as well as its implication in HAC reduction programs and overall penalties. We know that from a national basis, these are just some facts, that 1 in 5 intraurinary catheters are placed unnecessarily. And we know that CAUTI itself is responsible for about 40% of all healthcare-acquired infections. Unfortunately, in a hospital like ours, especially a tertiary quaternary hospital, we have very common use of catheters for good reason. But these obviously make it that we have a significant risk factor for nosocomial UTI in our facility. Nebraska medicine in our fiscal year of 2014 was revealed to have a 3.1 CAUTI rate, meaning that was our rate of CAUTI development at over 1,000 days of catheter use. That clearly was not in line with our overall annual goals, and was really kind of lifted up as an issue that we needed to address from an infection prevention standpoint. When we first anecdotally started talking about this, what we found is that we weren't always necessarily doing the right thing with catheters, meaning that the best way to avoid a catheter-associated UTI is to avoid the catheter in the first place, or to make sure that we are actually getting catheters out when we no longer need them. But when we talked about this with staff, they weren't always aware that what the indication for the catheter was, or whether it was truly needed. In addition, we weren't removing those catheters in a timely manner, nor were we actually taking care of the catheter in a way that was consistent, or at least documented consistently. And then finally, we had a lot of difficulty around sort of inappropriate use of culture and sensitivity studies, and we're probably actually over-treating and possibly leading to other lines or versions of infection by over-treating cultures that maybe were not actually significant. This is a little bit more of our background. This was our overall CAUTI rate per 1,000 catheter days. This reveals both our Nebraska Medical Center as a whole, then our ICU beds, and then just our med-surg floors over a 3-year period. Clearly, despite discussion, despite kind of the usual things through infection prevention means, we had not been able to move the mark in a direction that we wanted to go. Our indwelling catheter days. This is important because for each day that a catheter is in place, your risk of having a catheter-associated urinary tract infection will increase by about 5 to 10%. So what that means is by day 5, most patients, or about half of them, are already colonized with bacteria. By 30 days, infection, when you have a catheter in, is almost universal. So it becomes very important to be thoughtful about when we're placing catheters and how quickly we can get those out, and then the care that patients receive once those catheters are in. Our organization has a very robust system for prioritizing our annual goals. We have a system of quality governance that reports almost directly straight to our board. This was a purposeful design created in about the end of 2013 that reflected us trying to essentially flatten our reports into the board so that they would have almost complete transparency to where we would be having issues or where we were perhaps not meeting our inner hospital goals or external goals. That group consists of the advisory board overall, and then we have a dedicated board quality committee and a patient safety and quality steering group that really aligns and sets annual goals for us every year. Underneath that safety and quality steering group is a group of other committees that we have referred to as critical collaborators. These are folks that are doing work that are really doing the heavy lifting in terms of how we're analyzing it and assessing our processes. And those folks all come together via their chair and sit together at Patient Safety and Quality Steering to make sure that we have a good holistic analysis of where our problems exist and what needs to be on our annual goals. So as a result of that infection prevention issues and lifting up that CAUTI was an issue that we were facing through Nebraska medicine as a whole, the Patient Safety and Quality Steering Committee made this part of our annual goals and lifted up the fact that we needed probably a focused evaluation of this particular problem within our institution. They created what we have called our CAUTI task force, essentially. It was consisted of two essential components. One was a protocol development team, and the other was our electronic healthcare record implementation team. Quality steering established those goals for this task force. What was ultimately the goal is get us to zero. So reduce the number of indwelling urinary catheters placed, reduce the number of days that an IUC is in place, and decrease our overall incidence of CAUTI. A bigger, more holistic methodology was really to understand what is best practice when it comes to catheter-associated UTI and avoiding them, and how can we utilize all of our staff, how can we utilize and leverage our technology in order to be able to give the best care that we possibly can to our patients. With that, I'm going to hand this over to Nicole Terrell. She is our Director of Patient Safety and Quality for the Nebraska.
Thank you, Dr. Feddersen. So we're going to go through really how we optimized health IT to improve the care that we were providing here at Nebraska Medicine. The screen that you're seeing right now is our timeline of events. This was definitely an organizational initiative. We had support from our Quality and Patient Safety Steering Committee. We had support from our Board of Directors, and this truly was multidisciplinary. This wasn't nurses alone trying to drive the work. It was our nurses, it was our providers, it was our lab group. We really tried to take all roles and all avenues to really achieve success. So first, our task force met so that we could create action plans, outline what our next steps were. We developed some really strong solutions and established a protocol. And then with a large academic medical center and a large health system, there are a variety of governing bodies that we needed to ensure that we took all of our changes to so that we had the support and buy-in across the organization. So there's just a general list of the councils that we really engaged and sought approval from for the changes we were going to put in place. Now, I will say the list of who we went and spoke to is much longer than the list that you're seeing on your screen. And then we went live with all our changes in the March and April timeframe of 2015. So at Nebraska Medicine, we use the DMAIC method of problem solving when we are attempting to address issues or opportunities within our organization. So during the define stage of DMAIC is where we identified what were our measures of success going to be, what was the scope that we were going to outline. In the measure phase, that's where we got all of our baseline numbers. We knew what were our biggest areas of opportunity. We really knew where we needed to target and focus, and it really did need to be a system-wide initiative. In the analyze phase is where we identified best practices. We evaluated the capabilities of our electronic health record. We completed various literature reviews to identify what was our gap. Where were we missing the mark? In the improve phase, that's where we established what our implementation plan, and we got approval from all of our various governance structures. And then in the control phase is where we are tracking and monitoring our progress. So the solutions that we decided to implement at Nebraska Medicine, so really talking about what Dr. Feddersen had outlined in terms of what were our opportunities. How do we make sure that we minimize the number of catheters that get put in? If they are placed, how do we get it out as soon as possible? And then if they're going to stay in, how do we make sure that they are nice and clean? So the solutions we targeted were the development of an indwelling urinary catheter protocol. We established rounds between our infection preventionists and then the unit leadership so that they could go and have real-time conversations with the staff at the front line, do just-in-time education as needed. Like Dr. Feddersen also mentioned, we had significant opportunity with our urine cultures. we had identified that we were over-culturing and over-treating our patients based on faulty data. We also underwent a complete revamp of how our nursing and care, our certified nursing assistants are called patient care techs. We really had to revamp how they were being taught and what their competency looked like. We had a decentralized approach, and we really needed to go to a centralized model so that we ensured everyone was in line with best practice and being taught about the gaps that we had in our facility. So a little high level about how health IT was used, and we'll get into detail in the upcoming slides. But the first thing is we needed to address the fact that you could put in an order for an indwelling urinary catheter for any reason, and so what could we do to make approved indications that you are only able to put the catheter in if you truly need it? We also wanted to modify our documentation to support how we were documenting the status of the catheter. We also wanted to give you real-time information about how long the catheter was in play, when was the last time it was cleaned, do you need different decision support tools to help you identify if it's time for that catheter to come out. We wanted this to be very collaborative. This wasn't just the frontline staff, this was the nurses, this was the leaders, this was our infection preventionists, all working together so that we can eliminate this instance of harm. So we needed to make sure that we gave our leadership and our other departments tools that they could use to help the frontline staff. And then our last solution was modification to our urine culture panel. So to reduce the number of indwelling urinary catheters placed, we modified our indwelling urinary catheter order. So this is something that regardless of the electronic health record that you use, you could put into play in your facility. We had conversations with our medical staff, we had input from our urology team, our hospitalists, our surgeons, to really define why would someone need a urinary catheter. This is a hard stop. If you want to put a catheter into place, you must address why you feel that this catheter is needed. I will say in the beginning when we put out this order, it was very alarming the number of catheters that we had in place that didn't have an order associated with them. When we did deeper dives on that, we really found that a lot of these patients were coming from the emergency department and a catheter was placed during a crisis, or we had patients that had a catheter placed in an operating room environment and either was left intentionally but never got ordered, or needed to be needed to be removed after the procedure and was not.
What I really want to say was really very useful about using our system in this way is it allowed us to really see why do people choose to put in a urinary catheter. Because there are some very finite reasons that our professional societies tell us are when somebody needs a urinary catheter, and those weren't necessarily always the reason that they were being chosen for. Sometimes it was a convenience factor, etc. For our organization, what we found is that the top two areas that people chose a urinary catheter was for perioperative procedure or for anything that they felt required strict I's and O's or treatment for accurate I's and O's. By being able to drill down to that point, we were able to kind of provide some on-the-go training to see, do we actually need a catheter for every perioperative procedure? And our perioperative teams have been very proactive in terms of determining that just because you're coming in for a knee replacement, you may not actually need a Foley place. And if you're not necessarily dosing Lasix or dosing some other type of medication that is going to impact overall urinary output, you may not necessarily need a catheter in.
That's a great point, Dr. Feddersen. So at our facility, our orthopedic group has actually eliminated most instances where in the past they would have had a urinary catheter regardless, just because you had the hip or you had the knee replacement. And so it has been a huge culture shift for us here at Nebraska Medicine. I will say right now a work in progress is the indication for treatment decisions requiring accurate input and output. We're trying to develop an algorithm of what truly means that you're using that accurate input and output, and do we have different ways to obtain that data for our providers if they're not doing fluid replacements or they're not tracking I's and O's on an hourly or every other hour basis. So those are conversations we're having right now to take this order entry one step further. The other piece is we wanted to reduce the number of days that catheter is in place. So as a result, we standardize what our documentation looks like. We have a very robust electronic health record and a phenomenal decision support team and EHR build team who were really willing to investigate what were all the options and how can we truly help the frontline staff recognize and be aware that the catheter has been in for a certain amount of time or that needs to be removed. So this is something that our frontline staff use. It's called a work list task, and so it helps to display that the patient is due for catheter cares. At Nebraska Medicine, we drew a line in the sand that said, at minimum, we will do catheter cares at 10 and 22. Now, obviously, we do catheter cares more often depending on the patient's needs or level of incontinence or whatever's going on clinically with that patient. And our intensive care units have actually decided that they're going to do catheter cares 3 times a day, and they do it with eyes and O's. But this was just a tool to help let everyone know that it is due and that they can actually document right here from within the screen that care was completed. The other thing is we wanted to give them tools. We had a lot of frontline staff say that they weren't necessarily aware of how long the catheter had been in place. With us developing a urinary catheter removal protocol, we have some indications that the nurse can remove autonomously. So a great example is if we have a catheter in solely for the reason of collecting a 24-hour urine collection, if we've obtained that specimen, the nurse can autonomously remove that catheter without a provider's order. But there are certain indications that do require the physician's input. So if an indication is that we need that catheter for treatment decisions requiring accurate I&O, you'll see that we have a disclaimer at the bottom of the screen that will display to the frontline staff to let them know that they need to call the physician for removal orders if they feel like it's probably something that the patient can do without. We also wanted to make it very visual when a patient has had a catheter in for greater than 3 days. You'll see the yellow banner displays a long-term indwelling urinary catheter. We even started displaying this to our case management team so that when they're rounding with our frontline providers, they can help engage in those conversations and say, hey, the patient's had this in for X number of days. Is it time that we can get it out? So we're really trying to make these decision support tools collaborative and allow all members of the healthcare team to participate. The other piece that we started and what I briefly touched on is that our infection preventionists and our leaders do rounding with the frontline staff. We developed a variety of tools that they could use so that they could easily see which patients had an indwelling urinary catheter, how long the catheter had been in play, when the last catheter cares had been completed. So that way it can be an open discussion with that staff member, with the provider group, between the leadership of that unit and the infection preventionist. We've actually heard feedback, and I'm sure Dr. Fedderson's heard it more than I have, where the providers are saying, oh my gosh, the nurses are asking me about this constantly. So we just developed heightened awareness at our organization that we do not need these catheters in as long as they're staying in. And so the nurses bring it up daily, sometimes twice a day, depending on shift change, to really say, let's get these out. They really pride themselves on what they can do to get to that zero harm. One of the other tools we put into play is what we call our nursing dashboard. So a normal screen would only show the area that you work in. Because I oversee quality and patient safety, I do have access to all of our units, so it wouldn't look this busy for the normal charge nurse on one of our floors. But the intent here is that the charge nurse, or we call them the leads of every unit, could look at their specific area and they could immediately see what were the Foley catheters that had been in for greater than 3 days, who was missing catheter orders, and who has not had catheter care documented in greater than 14 hours. For privacy reasons, I don't have a screenshot to show you, but I will say that you can click on any of those numbers and it will give you a drill down of exactly who that patient is. So if I'm on 4 LAW and I see that I have 2 patients with catheters in and one has had it in greater than 3 days, I can start having the conversations with the providers and help support my nursing staff on making sure we're getting these catheter cares out. Same thing with the missing catheter care documentation. If I'm on 6W Northeast I can identify, I've had 2 patients that don't have documentation of their catheter care. Now, we truly understand that there are instances where the care might have occurred, but the documentation didn't happen. But we all know the old saying that if you don't document it, you didn't do it. So this is an opportunity for the team lead to follow up with the patient care techs of that patient, the nurse of that patient, and see if they can give them some help so that they can get the catheter cares done. The last piece that we really tried to optimize our electronic health record and really promote the use of health IT was decreasing our false positive culture results. So at Nebraska Medicine, we did a small study where we identified that almost 50% of the urine cultures that we were obtaining, the patient did not have signs and symptoms of CAUTI. They potentially had contaminated specimens. And so really, what could we do to minimize the fact that that was occurring? So in our system, we modified our urine culture orders. So as a provider, you have 2 options. You can either get a UA with reflex micro, or you can get a UA with reflex micro and a possible culture. Now, depending on which one the provider selects, if they select that they might possibly want a culture, they're required to document not only where is the specimen source coming from, but what are the symptoms that the patient is experiencing. We do have a certain population that we will define as special. So if the patient is neutropenic, if they're pregnant, if they're a child under 3 years, we will give them the urine culture as long as it's not contaminated. But in this instance, if you check this order, we will not process to a urine culture unless there's white cells in the urine, and as long as it's not contaminated, meaning that there's no squamous cells.
So this was really kind of a opportunity for us to collaborate with our infection control team as well as our infectious disease team. And what we're a learning, we're a teaching hospital. We're a learning organization. We have about 500 plus residents and fellows that rotate through. One of the things that we actually put into this, not only to give them sort of that real-time, as I'm placing the order education as to what really you should be looking for when you're thinking about a UTI, but if there's folks that then it comes up that they think they need a urine culture but they didn't get it because it didn't reflex, we've actually created a system where they can call directly to either myself or Dr. Van Schoenefeld, who is our head of infection prevention, or another one of our hospitalists, and discuss the case with them. And so we've actually been able to provide real-time feedback and education to our, not only just our residents, but sometimes our faculty as well, as to the reasons to get a urinary culture and that in order to cut down on inappropriate culturing.
Thank you, Dr. Pedersen. So while we might have a different electronic health record than you do, I do want to highlight that a lot of the work that we did was around coming up with a universal decision on what was going to be our order standard. What was going to be our order standard for both in placing the indwelling urinary catheter, what was going to be our order standard for the urine culture. And then in terms of the documentation, the decision support tools, and the real-time evaluation, that was a collaboration on how can we visually tell you and easily let you identify how long the catheter has been in and if it's been clean. Ideally, we don't want the catheter in. It's got to be in, make sure it's clean, and then let's get it out as soon as we can. So as far as our results, we did see significant success with our urine cultures per 1,000 patient days. We had a 50% decrease in the number of urine cultures that were obtained. This took a lot of education. It took a lot of hands-on work by our infection control and prevention team to really get out there and educate our staff. We also saw a 49% decrease in our contaminated urine cultures. Again, heightened awareness, education, so that we are not collecting dirty specimens. You can also see our CAUTI rate over the last 4 fiscal years. So in fiscal year 14, like Dr. Pedersen had alluded to, we were much higher than the baseline that we had desired. And then you can see in fiscal year 17, we were a little over 1.5 as our CAUTI rate. we saw a 47% reduction in our CAUTI rate and a 29% reduction in our catheter days. Now, I've seen organizations that have been able to get to zero and they've been able to sustain that zero, and we're really looking forward to being able to have those types of results here at Nebraska Medicine. I can proudly say that in June of this year was our very first month where we had 0 CAUTIs across the entire system. Now, I know, again, there's organizations that demonstrate that year after year, but that was the first time Nebraska Medicine had been able to demonstrate those results. We looked all the way back to calendar year 2008, and we had never seen 1 month with 0, and we even had some months that were as high as 24 CAUTIs. So for us, it was a lot of pride and a lot of passion to try and get us to that 0 number, and now we know we can do it. I can say one of the takeaways and one of the lessons learned here for us at Nebraska Medicine is that we stopped using SIR rate, CAUTI rate. We stopped using these kind of arbitrary numbers when talking with our frontline staff. To us on quality and to those of you that are infection preventionists, and even for our infection preventionist team, obviously the SIR is very important. The CAUTI rate is very important to trend. But when we talk to our frontline staff, we talk about number of patients harmed. And to them, that is a lot more tangible. If you tell them 40 patients were harmed, 30 patients were harmed, and that's someone's family member, someone's mother, brother, child, to them it is a lot more impactful. And so we stopped talking to them in terms of rates, started talking to them in terms of numbers of lives impacted. And we've seen a lot of success at Nebraska Medicine as a result. The other thing is there are some realized cost reduction associated with getting to that 0 harm goal. Every catheter-associated urinary tract infection at our organization is going to cost additional money. It's going to cost dollars related to treatment. It's going to cost dollars related to an extended length of stay. And by us decreasing the number of lives impacted, we've also been able to see a $1.4 million in savings by continuing to work towards our goal of 0 harm. We still have a few things in progress. This is not going to be one of those journeys where, hooray, we hit our 1 month of 0 and we never have to look back. This is going to be something we are going to have to maintain and sustain and never take our eye away from. So we are continuing to focus on how can we get that catheter out in a timely manner. Like I had mentioned, we're also focusing on why are you putting the catheter in. We created something called a quality measure checklist that can clearly display to our providers that the patient has a catheter in, how many days it's been in, and then they have a one-stop shop where they can either say they'd like to continue it, and this is the reason why, or they can order the removal right then and there.
So when we use Health IT here, one of the things that we heard loud and clear from our frontline staff is please don't stop my workflow. And many organizations use best practice alerts or pop-ups, whatever you want to call them, as a way to get people to do what they wanted them to do. What we have actually tried to do is something a little different. We've tried more on the educational side, more showing things that weren't necessarily a stopper of someone's workflow, but was more a reference tool. So the daily checklist that now we've rolled out and we're working with is something that actually takes all of the things that revolve around our quality measures, so our central line data, our CAUTI data, our VTE prophylaxis data, and puts them in an area of the chart where that physician or that nurse practitioner can take a look at them in their own workflow. So if at the end of the day, what their workflow is to check on their patient's quality measures, they can do that without necessarily having to put a pop-up in. Now, we have connected that entire section to something that will eventually alert the provider if it has been a certain amount of time and they've not acknowledged their quality checklist. But this is another way that we're trying to make Health IT work for our frontline staff and not necessarily interrupt their workflow, because we know that their efficiency and their time is valuable.
So that's great. The big thing with Health IT is we want to try and make it simple for our frontline. If we give them a lot of different clicks, a lot of different buttons, too many workflows, we're just making the process more cumbersome. And so a lot of the work that we do here at Nebraska Medicine is how do I make it easy for you to do the right thing? And how do we help to reinforce that right process? So, you know, at Nebraska Medicine, our overall model is that patients, first and foremost, do not want to be hurt while they are in our facility. They want us to help them, and lastly, they want us to be nice to them. And so that is the overall message that we are trying to display to our frontline staff. And it's really health IT that's helping us pave the way to get there. So with that, thank you so much for listening to us here at Nebraska Medicine. You could always reach out to us for questions.
Thank you both, Dr. Feddersen and Nicole, for that great presentation. I also want to remind folks where to find this recording and other Davies Award winning use cases and information on how to apply for Davies Awards. That information can be found posted at the HIMSS Davies website at HIMSS.org/Davies. Again, that information can be found at the HIMSS website, www.HIMSS.org/Davies. And thank you so much.